Okay. Like so many before us, we have a lot to tell you all and not a whole lot of time to do it in. So I'm very appreciative of the presentation before us because we're actually not going to be talking about presentation and the idea of signs and symptoms and anatomy. Susan and I are going to be talking a lot about the article that Dr. Francomano spoke of that came out in 2023 that we had an international team that worked on. And we're going to be talking about the importance of the severity of presentation, especially for our rehab professionals, to be able to classify and provide the right treatment strategies for each of these individuals based on what we think the severity of the presentation is. And next, there we go. So it's important to understand, especially for our rehab providers out there, whoever that provider might be, that when we're looking at the clinical presentation of instability, upper cervical instability, we're actually really looking at the severity of the symptoms. So how reactive is the individual? Because they're going to be just as reactive to our interventions. So this is really a lot of subjective that we explore with them. This is really through our subjective intake, really learning a lot about their story. A lot of times when you specialize in EDS, in our professions as rehab providers, there's a lot of talking for the first few sessions, and there should be. We need to understand their story, how reactive they are. So again, all of this information is in the paper, and I really want Susan to have time to tell you about the interventions too. We're going to sprinkle in a little bit more than what was already in the paper, but I'm going to talk about the severity of presentation, and this is really important because we want to make sure that we are prescribing the right treatments to the individual. We can have this variety of symptoms and also a spectrum of severity with each individual, and we don't want to treat all the same. And we certainly don't want to treat our mild cases because they don't look like our severe cases. So we had put together this group, and what we came up with was, as specialty providers, we kind of break this down into understanding how severe, and I'll talk about what severe means, how severe they are and how often that is, and then how easy can we flare them up, and then the third piece is how quick can they recover from that flare up or whatever might have irritated them. So again, this is a lot of subjective, a lot of talk, and then we have to understand that we can't assume that somebody is in a presentation just because of what they look like when they walk in. So we have to remember that as we're talking to them, our idea of their level of severity might change. So we might think that they're a mild, and as they're just answering questions, they're developing more neurological symptoms. Or as we're taking them through exams and asking them to do things, they're actually regressing a little bit as we're watching them. It can also fluctuate in between sessions as well. So we have to be on our toes. When we talk about this mild group, so mild presentations, mild severity, they tend to be low irritability groups. They're not usually always severe, as we'll talk about what that means in a moment. They're not as easily flared up. When we have perturbations or they jerk to go get something, it's more of an expected result that we see from them. And then it doesn't take that long to recover. It's more of a typical recovery that we see. But when we get into this moderate group, this is where things start to become a little bit unpredictable, especially in the rehab world as well. When we talk about severity, it's more intermittent. We're seeing more flare-ups in these individuals, and when they do flare up, it's a lot more difficult to calm them back down. These highly irritable group, and I think for a while this is what we stereotypically thought of as our upper cervical instability. They all have to look like this, and they most certainly do not. It's a very wide spectrum that we can have. But we're seeing this severity, this severe presentation, highly irritable more constantly. We're seeing that it's very, very easy to flare these individuals up, and it takes a very long time to calm things down. So when we talk about severe, what we're talking about in our highly irritable, more severe presentations, or when we talk about a flare-up, these are the patients that don't like to be vertical, okay? These are the patients that might be more bed-bound. They might come in with ambulatory aids or even leaning on somebody else to get into the clinic. And it might not be all the time, but definitely these ambulatory aids are pulled out more for neurological symptoms that are related to the upper cervical spine, not necessarily to pain or weakness that we can also see. They might report muscle guarding, or they also might have more severe reactions from being touched, so reports of failed therapy elsewhere. We see much more neurological symptoms as we progress into this moderate and severe presentation. So we might have reports of choking, difficulty swallowing, voice changes reported, these visual disturbances. They might have more severe nausea with neck movement. We see a lot with neck rotation and into extension as well. And for those that use functional outcome measures for our physical therapists, if you're using any that we would use for upper cervical problems, if we're pushing them into the more severely involved category, we're going to consider them more severe. When we talk about easy to flare up, that's just what it means. They're very easy to flare up. Something happened to them, their body, and they had a reaction that we wouldn't expect. Prolonged time to recovery, this is really, it can be pain or it can be neurological issues as well. When we're talking about a more severe population, it can take up to 24 hours for pain to resolve in our more severe presentations when they are flared up, or even several hours for the neurological symptoms to really start to calm down. And this is our paradigm that we have. So with our paradigm, and this is really great for all our physical therapists, and to also understand that in a week, a patient might actually fluctuate in all of these different levels that we have. So the level of severity can actually fluctuate in between sessions and over time. And eventually we actually want to move our individuals from that high irritability group down to the mild irritability. And again, we're not talking about anatomical instability. We're talking about their presentation, because we can have mild instability and still have a pretty severe presentation depending on so many different factors. So when we have our highly irritable group, this is really a lot of education, a lot of neural calming that we do with them. Our moderate group that we have, we can start to put in more what we consider neuromuscular control, proprioceptive exercises, and things like that. In our mild presentation, and when we say aggressive, we're talking about aggressive for instability. So aggressive is what we kind of think of standard physical therapy exercises, strengthening. So moving through the range of motion and trying to add strength to it. We really want to focus on stability and control and alignment before we get into what we consider more aggressive for instability. And Susan's going to talk a little bit more about what falls into those categories. I'm going to take just a moment to talk about neck bracing before I hand it over to Susan, because I know so many people have questions about neck bracing. And like so many things that we talk about within HSD and EDS, it's independent for the person. But that doesn't mean that we can't figure out how to do this for each person. And it's really important to find somebody that knows how to fit neck braces, tell you when to wear it, how to wear it. And there's really no information out there whether it's beneficial or not. There's no research as of yet. So the rest of what I'm going to present here is expert opinion, and you definitely want to find somebody, hopefully locally, that can help you, again, figure out how often to wear it or not. If we can get a custom fitted collar, especially for the rigid ones, have somebody take a look, or even a soft collar, I do highly recommend that. We want to make sure that you are wearing it in a good position. Even the rigid collars are adjustable, so we want to make sure that the head is in a correct position. And sometimes having those measurements and where you are in flexion and extension can help your physical therapist bias you into a better position. With our brace options, a lot of times we talk about the Miami J, we talk about the Aspen. There's some collars out there that they do have on the market that are absolutely fine and can be fitted and helped out with your physical therapist. So again, individualized care when we talk about the neck brace. We actually really don't want to keep our patients in the neck brace. They shouldn't be wearing it more often than not. So we usually tell people, especially in the beginning with our wearing schedules, we'd like to get people to the point of wearing it 10 to 15 minutes for symptomatic relief. And our patients that have mild instability or these mild presentations, they might not be wearing it even that often. They might just be wearing it for travel, or again, during flare-ups, maybe once a week. We really don't want our patients wearing them for more than 4 hours throughout the day, okay? We do know that if we have somebody immobilized for a period of time, that we can actually start to lose some of that deep cervical stabilizing muscle activation that we want to have them hang on to. So it is a bit counterintuitive. So if we ever have anybody in a rigid collar, then we want to make sure that they have a plan of doing these isometrics, neuromuscular, muscle energy techniques, whatever it might be with your therapist, that you're doing those on a regular basis throughout the day. So if you are braced more often than not, you should have a plan with a therapist of what you are doing to help keep those stabilizing muscles active. We do have surgeons that do recommend wearing these 24/7. And again, that might be a little bit biased because if you're seeing a surgeon, you're probably on the more severe spectrum. But at the same time, there are prescribed exercises. So again, we have to make sure if we're in the brace that we have a plan moving forward. Okay? So I am going to hand it over to Susan because she has a lot to say.
What am I hitting here? Just here? Mm-hmm. Okay, great. All right. So we're going to hit the ground running because we have a lot to cover, and I'm speaking also to hypermobile patients. So listen to this because you guys are the advocates for your care, and when you go into physical therapy, be careful. I mean, any activities that they give you should not be increasing your symptoms. If it is, you need to speak up, let them know that it's increasing your symptoms, and then you should stop, back up, see if they can modify the activity. If they really want to work on that at that time, they might have to kind of downgrade what they're doing and think about what they're doing to be able to find that functional place for you to start. So as a patient, advocate for yourself. It's not okay to increase your symptoms, okay? Then stop and you'll find something else to do. So starting with general considerations and activity, starting with aerobic exercise. So in a severe severity or a severe state of irritability, you can do things as simple as as a patient or therapist, you have your patient just lay against the wall, legs up against the wall, and do wall slides. Okay, so that way you're supported in alignment, and you can control the amount of movement that's going on, all the way up to our mild patients who are returning to sport. So they may be using aerobic activities such as swimming or running, but again, with and without precautions, you have to be careful with that and really look at the patient's limitations and not push through. Let's talk about severe presentation of treatment at first. So first thing you need to consider is safety netting. So you're just getting to know your patient. They're in a severe irritable state. A lot of them come to me that way. So you have to know kind of what is triggering their symptoms and what could send them into kind of an overdrive of their symptoms to where, it could be an emergency situation, or you might recommend follow-up to their physician at that time. But what you can do as a therapist and patients, what you can understand is you have a current functional level. So that's where you're going to start. So if you're bedbound, okay, we've got lying down, you may get up and go to the bathroom. So let's work on sleeping or lying down positions in postural alignment, supporting the spine, using pillows, using supports, using, for the kids, stuffed animals even. And so then working on sitting, proper sitting posture so that you're decreasing the amount of harm to this patient, even though there's a level of energy expenditure going on, but being aware of being in alignment is very important. So again, just working at that patient's functional level. Where are they currently, where they can exist without increasing symptoms, and that's what you have to keep in mind. Again, first work on static positions, again, lying down positions, sitting positions, standing positions. And then from there, being very aware of the alignment that you're in and the position that you're in. And make sure that you're always correcting yourself. We're human, we fatigue. Our muscles are an active system, they're going to fatigue. So we have to be aware of when we're fatiguing to really stop and change what we're doing. So if you've been sitting up for a while, can't hold your posture, you can get up, you can walk around, you can lie down. Assess what you have where you're at. So if you're in a classroom situation, you may not be able to lay down, more than likely, but you can sit, stand, walk in place, move around. If you are home and you're working at home and you have the ability to go lay down for 5 minutes or 10 minutes, do, put that into your cross training. It's decompression. Avoid also big neck motions with your severe patients. So, really just belly button, nose in line, so they're turning together, so that when you are turning, you're turning from, with core stability or in alignment, so you're decreasing the amount of irritability to the neck with movement. Body mechanics, ergonomic training, joint protection. Joint protection includes your supports and bracing. If you're a busy mom, if your job requirement or your school requirement's more than what your functional level is at and it's increasing your symptoms, you may need that added support to help you when you have to push through to complete, your requirements. Again, orthotics, looking at orthotics and shoe wear, so supports. Again, that's your foundation. That drives your functional alignment. If you have a faulty foundation, so we've got the collapsing arches, and if that's where we're starting and we have a very hypermobile foot, it's a lot of moving parts in your feet and ankle, we need to support that correctly. So take the level of activity that you're going to do, mindfulness, awareness, and match that with the shoe wear, the support that you're going to need for that activity. So be aware, plan ahead. So again, building a functional foundation, a stable foundation, is going to support your alignment up the chain to carry your 12-pound pumpkin on your toothpick. So next thing, with the severe patients, very important that we do pain science and self-care. So here again, relaxation, autonomic nervous system. So vagus nerves, just calming that whole system, the whole nervous system. That may be where that you need to start with that patient. Breathing, diaphragmatic breathing, slow, deep breathing. And again, just addressing catastrophization, just being mindful of the language that you use with your patient. If they're, a little distressed, especially at this level, then talk to them very gently. Try to be very understanding with your language, because they're already in distress and they don't need you to kind of, push them even harder to be tougher and things like that. Listen to them, be very just gentle with them. Again, address your pain management, things like heat, ice, TENS, CBD balm, anything like that helps that patient. And they may have to kind of explore a little bit to find what works. Motor control, very important. So the way you move is very, very important. So at the severe irritability status level, these patients may not tolerate this motor control, situation. You may have to start at just the level of being supported, lying on your back in supine, proper alignment, and starting with maybe just eye movements. Eye movements alone kind of help influence where the C1 level is and the position of it. So you might have to start there. As a therapist, we have to work with our patients. And again, you have to be kind of a therapist that has some expertise in this to really understand it. Again, working more remotely, working at the, when you're lying down, you're sitting, your primary foundation is your pelvis. When you're standing and walking, it's your feet. So start lower down, start remote, because everything's connected. So whatever you do at the bottom at the foundation is going to affect everything up to the pumpkin on a stick. So again, start with just lying that patient down. Don't expect, to get them up and moving in the beginning. So manual therapy for severe patients, just be very, very careful. Again, start very remote. It's the safest thing to do. Get your effects from there. They may not, if they're super irritable and hypersensitive, they're not going to tolerate it. Drop it for that day, and you can start again later. But always start very remote. Never go straight to the neck, okay? So be cautious about the different things that you do. And again, your more experienced clinicians are going to, understand a little bit more of what they can and cannot do. So as a patient, look for somebody who has experience in this. Interventions to avoid with these patients, anything that has moderate to large neck movements. Axial loading and distraction, that includes traction. So cervical traction. Again, when you're doing that, a lot of patients will either say they feel really good or really bad. So when you're stretching those ligaments, out, intraction, you're unloading, and taking pressure off the neurological, system. But the thing is, the after effects of the muscles fatiguing is going to very much affect them. So I know I'm short on time here. Again, be aware of positioning, that has to do with neural tension. So again, the pelvic tilt might aggravate somebody with tether cord problems. Okay, so everything we just talked about with severe patients is game for moderate and mild irritability status of your patients. So again, concentrate on posture and body mechanics. We went over all this. Start at the level of function that your patient is currently in and able to tolerate. All right, and so here, moderate patients, we move a little bit more towards proprioception, motor control, and strengthening, working again, even in those areas, very remote, so away from the neck, and then working towards the neck. Here you can add in possibly some very gentle axial loading, and also just make sure that when you start to add in some cervical isometrics at this level, at that moderate irritability status, that you're starting at a very low load, so back to that 10% or less. How's the patient, how do they tolerate it? Are they okay? Can they do a little bit more? Or maybe just stay at that level for that day and see what their symptoms are later before you move forward. Manual therapy, same thing, just be very, very cautious. We went over this. Here you can do a little bit more. Your therapists that understand a little bit more can start to work closer to the neck, and maybe a little bit of decrease, just over engagement of the sternocleidomastoid, those superficial muscles on the front of the neck that carry the head in a forward posture, kind of inhibiting those things. Mild severity, okay, this is where we work back into function and sport exercise. What I warn here is just make sure that you're taking baby steps as you bring this person back into function, especially if there is increased speed, force, or torque going on. Baby steps all the way through. Really have them prepare before you return them back to that type of activity. So here, just, you're adding in coordination and all of that. Again, mild severity, muscle energy techniques, real quick, I want to talk on that. That is your own muscles aligning your spine or aligning your joints. So using your own muscle energy is probably the safest way to do it versus having having somebody come in and using an external speed, force, or torque type of manipulation, mobilization. Stay away from that. That's really damaging unless your therapist really, really knows what they're doing. But even, gentle force can damage a patient and take them from a mild state to a very severe irritability state. We want to see over time that patients who are in a severe irritability state gradually work towards that mild irritability state. The instability is there. It's going to be there. So we always have to manage it. So that is our goal, okay? General concepts, make sure that you're starting easier, less is more. Start slower and further away from the cervical spine because they're hypersensitive. Again, work at the foundation, okay? So feet, pelvis, and then slowly work up, okay? Lumbar proprioceptive training and cervical proprioceptive training, both of these. Again, what's important about this is first you have to have a functional foundation. Once you get that functional foundation, you can help the patient work towards functional alignment, which in turn drives functional movement or functional motion. So if you don't have a functional foundation, you are never going to get functional alignment or functional motion, okay? So keep that in mind. Biofeedback, very, very important. Biofeedback, cueing, all of that stuff is going to help that patient kind of start to understand how their body works, okay? So again, where am I in space with proprioception? So again, you got a 12-pound pumpkin on a stick, and whatever happens up here is a result of what's going on down there. So you have to work up. Biofeedback, like I said, cueing, anything that you can get the patient to really understand what you're asking them to feel. It's about what you look like, or what you feel like, or what you feel, not about what you look, when we look at a patient, it's an imbalanced system. So we have a dominant side, non-dominant side. So cervical spine proprioceptive training, again, progression is, just Start with static posture, okay, and then work from there with small dynamic movements. Start, lower down and work your way up to the point where once you're in alignment, then you can, when you get to cervical, start with very, very small motions before you progress to larger motions, baby steps. Start supine and then progress to, you can go to side lying, seating, standing, and then quadruped where you're against gravity. Okay, so very gradual. All right, and tongue to palate. There was a nice poster presentation at the combined sections meeting that we all spoke at. And it's funny, so having this poster presentation, tongue to roof of palate helps to increase deep cervical stabilization. So it helps strengthen that. And I've had so many patients over the years tell me, I have to hold my tongue to the roof of my palate to actually hold my head on. So seeing that, I was like, aha, it was a great aha moment. So, it's nice to see where this goes research-wise. Strength training. So start, again, we've talked about this. So again, starting with first proper alignment, from proper foundation, proper alignment, then you can start working from isometric to actually dynamic movement and strengthen that way. That's your safest way about going about that. Muscle energy techniques, we've mentioned that influences the position of C1. So work with a therapist on that, somebody who's knowledgeable. Summary, so treatment choices should be based on clinical presentation of severity, not on anatomical findings. So just make sure that, listen to your patient, okay? Or you being a patient, don't belittle how you feel. I mean, how you feel, it's the full gamut of the emotional, the mental, the physical, everything comes together and all that. And there's a lot of things that we can do in PT to really bring that irritability status down. The spine must have a stable base. We've talked about that. Start very, very low and then go slow, baby steps. And every case will be unique, and prognosis and outcomes can vary. So again, make sure you're working and starting at the level of function. We're breathing, we're existing, we're living. We've got to correct there, and then we can start to progress, progress up from there. Again, just working individually with each patient. Don't work based on a diagnosis. Work based on the current presentation of your patient, because it's going to change from day to day, week to week. And so anyway, thank you very much from our upper cervical instability team from our paper, and just representing them. Again, here's our references for our talk.